Next one. One of the problems is there is just way too much to learn. You know, this is from probably the 1980s or 1990s. Remember when you used to get all of this stuff that was sent out by mail, hard copies? You know, magazines and advertisements and journals and newspapers and so on. I think I just let this stuff sit on my desk for, I think it was a week or two, and it just piles up like this. Well, it's even worse now. Next slide. The doubling time of medical knowledge has just exploded. In the 1950s, medical knowledge doubled every 50 years. By 1982, it was every 7 years. 2010 is every three and a half years. And now it's every 73 days. Medical knowledge doubled. Less than 3 months every time. There are now over 3 million articles published every year. It's impossible to keep up. Next. Not only are we bombarded with the journals and medical literature, but we get all of this stuff by email and social media and everything else. In other words, you probably get these. I get them every day. The AMA, the ACOG Today headlines. They send out all of this stuff to read. Part of it, I think, is so you know what your patients are reading. But look at the today's headlines. They're top news stories. Pregnant women with diabetes may have higher risk of stillbirth if they have obesity or poorly controlled blood sugar, study suggests. How many didn't know that ahead of time? I mean, we all know that. They don't have to send this stuff out to us. Next slide. Well, how do physicians keep up? About 78% still read medical journals, the hard copies. About 68% consult a lot with their colleagues to consult with problems and to keep up and so on. About 65% go to meetings like this, CME meetings and so on. About 64% have various kinds of apps now, of all kinds, and this is getting increased, in fact. And about 62% are using now online medical journals, which can be a problem too, and I'll say something about that. Next slide. Now, I think we have this idea that what we do is very scientific. There's a study that's done, it's peer-reviewed, it's published, and then societies, and we take it up and use it in our patients. Really, that's not usually what happens. There's a lot of fads and publicity. For example, there's a wave of enthusiasm about a new drug or a new treatment, maybe based on a study or two. And then after it's used for quite a while, all of a sudden the complications, side effects, and everything start turning up. So everybody gets down on that new drug. And then finally, after it's used for maybe several years, it kind of settles out in where it should be. But there's a lot of fads and publicity, a lot of emotion, a lot of opinions, and editorials, and sometimes facts are way at the bottom. Next. And that was the reason for the evidence-based medicine movement. Evidence-based medicine means this: first, do no harm. Now, that's not always happens in practice. 2, what are the results? 3, are the results valid? And 4, how do I actually apply those results to my patients? Next. Evidence-based medicine really is a pretty recent phenomenon. Even though we talk about it all the time, there weren't any randomized trials, for example, until about the 80s or 90s. Randomized trials are that new. But they've exploded. You can see in 2013, last time I looked at them, there were over 14,000 reported that year. And meta-analysis were even after that. They didn't start until the 1990s and early 2000s, but they've caught up with randomized trials. So there are just as many or more meta-analyses now as there are randomized trials. Yet you need the randomized trials for meta-analyses. So there are way too many meta-analyses done over and over now. It's called the meta-analyses metastasis. Next slide. The number of published papers with evidence-based in the title has skyrocketed. Why would you put evidence-based in the title? because it sounds good and attracts readers, and this is evidence-based and so on. Some of them are, and some of them aren't evidence-based. But now there are over 100,000 papers a year that say evidence-based in their title. Next. What is it? What is evidence-based medicine? It, first of all, de-emphasizes many of the things that we've used in medicine for many years. It de-emphasizes intuition. For example, this is really a good idea. We should do this. Maybe as some of the suggestions that have been brought up this morning. It de-emphasizes that. It de-emphasizes experience. The person that's done 1,000 operations and this really works and so on, and so this is what we're going to teach. It de-emphasizes that. I'll have to say that I don't really believe this part of evidence-based medicine. I believe that experience is important in medicine. It de-emphasizes the basic science. It de-emphasizes the pathophysiology. Why does this really work, and how do we do it? What it does emphasize is primarily two things. Show me the proof that this actually works in clinical care. And two, show me the outcomes, that it improves clinical care. Next slide. Well, these rules of evidence-based medicine were established by Bogsat. Does anybody know what Bogsat is? It's a bunch of old guys sitting around a table. They weren't established by evidence. They were established to say randomized trials are the gold standard and others are not as good. The guidelines for publication, though, have helped a lot in the way studies are published. Consort guidelines for example, randomized trials. It used to be that, if you had an idea and you believed in it, you could do a review and cherry pick the literature and could support your idea. You can't do that anymore. You have to follow the guidelines about how you actually, for example, search the literature and do a randomized or do a meta-analyses and so on. So these guidelines have really improved the publication of studies. And I think it's really improved the quality of papers. But interestingly enough, the evidence that these have improved patient care is still pretty sparse. Next slide. Well, I think we can agree pretty much that randomized trials are probably the best kind of studies. First of all, they eliminate a lot of bias. They're blinded and so on, and so they're more objective. It's probably the most reliable evidence. But most of them are designed for efficacy only. Randomized trials are expensive, they're short-term, they're usually designed to prove that this drug is better than this one or that this treatment is better. And usually they only report odds ratios and confidence intervals. How many of you have tried to talk to a patient about odds ratios? I mean, it's impossible. And yet that's the way all these things are reported. So at least at the Green Journal, I insisted that they had to report absolute risks. Actual numbers, percentages, numbers needed to treat, and so on. The other thing that I think isn't appreciated about randomized trials is 25% of them are later refuted. So they're not gospel. They can be wrong, particularly the first ones. Next slide. There are also problems translating randomized trials into your practice. First of all, to do a randomized trial, you need two homogeneous groups that you can compare equally and fairly. So maybe one group has a half a dozen diabetics in it. The other one has three hypertensives in it. You eliminate those so that you have two homogeneous groups. Well, guess what patient walks into your office that you want to use this new drug on? It's probably a hypertensive diabetic. And does it really work the same way? Also, these new treatments are often they cost a lot more, and that's never reported in the paper. Maybe the insurance won't cover it. Maybe the patient doesn't want it. Her aunt had one operation 5 years ago that really worked well. You've got a new one and better and so on. She doesn't want it. She wants what her aunt had. Not only that, but the most important thing, I think, is that these unanticipated complications or side effects start turning up later. So I don't think you ever have to apologize if you don't use the results of a randomized trial in your particular situation, in your particular patients, because you know your patients. And that's not the way it's kind of presented. Next slide. The reality today also is that randomized trials have been kind of contaminated. 75% of clinical trials now are industry funded. What's the purpose of a company that funds a randomized trial? Well, it's to get a good outcome for their new drug or their new treatment or whatever. So only a third of them are now done in universities when almost 100% used to be. So you have to be careful about who controlled the data, who wrote the paper. There are many ties in these authors and investigators with companies, even with the guidelines, not ACOG's guidelines necessarily, but many times the experts that wrote the guidelines really had ties with companies and so on. And it's been well shown that if a company sponsors a study, that there's a 4 to 5-fold increase that there's going to be a favorable outcome for that particular drug or that particular treatment. It's not that they are not reported honestly, but they have this spin about how they're interpreted and what the conclusions are and what the results are. Next slide. Now, there are a lot of challenges for randomized trials in obstetrics and gynecology and surgical and gynecologic surgery. First of all, randomized trials are very difficult to do. You can't randomize the obstetrician. I mean, you can't blind the obstetrician. You can't blind the surgeon. And lots of times you can't blind the patient. So cohort or case control studies are often our next best kinds of studies. I do believe, though, that whatever study is done, that you should have to compare with the present drug that we're using or the present treatment that we're using. Now, a lot of companies don't want to do that, particularly with the drug, because it might not look that much better than what we're using. And so they would prefer to compare it to a placebo, because it's almost always better than a placebo. But I would say that we ought to always have them compare it with the current accepted method. Next. I think it's important to remember these things. Efficacy is what happens with a randomized trial under ideal conditions. Effectiveness is what happens in your real clinical practice, and they're not the same. No randomized trial fits every patient. Almost no randomized trial fits any patient perfectly. And as I said, they're short-term results only. Randomized trials are not good for detecting complications and side effects. Next. Now, clinical judgment, I want to say, is always going to be important. It always has been, and it always will be, despite evidence-based medicine. And this is just one example I'll give you. You may remember a few years ago in New England Journal, there was a randomized trial that showed that if you did an abdominal sacrocolpopexy, first of all, you know that if you do that, you pull up the UV angle, and some of those women will get stress incontinence, or you may aggravate stress incontinence. So what they did is they randomized this study at the time they did the sacrocolpopexy to do a Birch, which is a retroperitoneal or retropubic suspension, at the time they did the sacrocolpopexy. And what they found was that they lowered the incidence of stress incontinence from 44% to 24%, about 20%. But what you might notice is that most of those patients did not have stress incontinence. And in the real world, what happened, I still remember this patient who was presented at M&M. As soon as this study was done, our residents and our faculty decided we need to do this then in every patient that gets a sacrocolpopexy. So what they did is they opened the spacer retzius to do the Marshall-Marchetti, and they noticed that this patient had a lot of varicosities there. What did they do? Well, they did it anyway. They put a needle right through the varicosities. She had bleeding, a big hematoma, 8 units of blood. This patient probably wished that her doctors had never read that paper. In other words, what I'm saying, clinical judgment is still important. She could have had a simpler sling or something later. She might not have even had stress incontinence. So whatever randomized trials say, clinical judgment is still going to be important. Next. Well, what about meta-analyses? As I said, these are state-of-the-art reviews now. And the advantages are you have to do them with the rules, the standard rules now, the way you include all the literature and so on. It's also a way of increasing statistical power if you put a bunch of randomized trials together and look at the outcomes. I think what isn't appreciated often are the disadvantages of systematic reviews and meta-analyses. I've always thought that every resident and every fellow should have to do one, because if you do, how many of you have done a meta-analysis? Anybody? Well, if you ever do one, you'll see that there are a lot of subjective assumptions about which patients you include, which studies you include, and so on. And it's really kind of a complicated and artificial way of doing research. They're also only as good as the trials used, the published trials, because they use the published trials. Well, if the trials were negative and so on, they probably weren't published. They also report in odds ratios and confidence intervals, as I said. But I think the most important thing is a lot of people haven't been trained in them. And so it's a complicated sort of thing to do a meta-analysis. And so we just assume, well, it must be right. Well, that's not really true. They can be just as flawed as any other study. And they're also very hard to keep up to date. Next. So statistics are sort of like this. A fellow with one leg frozen in ice and the other leg in boiling water is comfortable on average. And a lot of statistical manipulation is kind of done. So a lot of statistics are sort of like this. Next. All this started, by the way, pretty much with the Cochrane reviews. And I think they still are the most well-done systematic reviews and meta-analyses. They still can contain some publication bias because they use published studies. They also are very long and boring. The one I included here, I think, was 140-some pages long on one topic. Well, who has time to do that? Who has time to read these things? They often conclude, well, there is insufficient evidence to say that this is better than this and so on. Well, you know, that doesn't help anybody in clinical practice. We already knew that. There also is limited access to these to some people. If you don't have a university library or a hospital library, you have to have a subscription to this, which the last time I checked was over $500. Well, you know, who's going to do that? There is one state in the United States that makes these free, by the way, to all their docs in the state. Anybody know which state? It's Wyoming. They've made it free to every doctor in the state. But anyway, again, they report in odds ratios only. Next. Not only that, but at least 50% of what we do every day, there is no randomized trial for and never will be. Either it's unethical to do a randomized trial, or it's too expensive, or it's just impractical and it never will be done. So we'll always have to use clinical judgment for a lot of things we're doing in obstetrics and gynecology. Next. For example, there are no randomized controlled trials for these. There's never been a randomized controlled trial to show that a trial of labor after a cesarean section is better than a repeat section. And there probably never will be, because patients know which group they want to be in, and docs do too, and so it probably never will occur. There are no randomized trials on cesarean on request, many surgical procedures, and many new materials and devices. Next. So cohort studies and case series are still useful. Now these have kind of fallen out of favor. There are journals that won't publish some of these kind of studies. They say they're too small or they have bias and so on. And you do have to realize that there is an increased chance of bias. But if they're done with the guidelines, they can be very well done. These are often the way things work in the trenches because you can have a long-term follow-up on these patients for years and years and years, and you have a lot of patients. And this is the way actually the first reports on adverse events or rare complications first turn up. Next. I'll give you a couple examples. This is a landmark study, I would say. It's an observational study. It was the first description of AIDS based on the clinical findings in 5 patients. In other words, Gottlieb was an assistant professor of medicine at UCLA. Schaff was his chief resident. They put it all together. They had these 5 patients with AIDS, and they understood what the signs and symptoms were, how they acquired AIDS, what the immunologic findings were. They were the first ones to describe it in 5 patients. Fortunately, New England Journal published it, but many journals probably wouldn't publish this sort of paper these days. Next. I always use this as an example of a case report. There are journals that will not accept case reports anymore. This is a useful case report. It happened in our own place at Utah. It was the first successful embolization for severe postpartum bleeding. And you never forget these patients. But in Utah, Hill Air Force Base has a hospital right north of Salt Lake City. They had a small maternity unit. I don't think they had an OB-GYN, but they had a family doctor or 2 and some nurse midwives. They did some deliveries there. And this was a completely normal multiparous patient, had a normal delivery, spontaneous delivery, but she started having a hemorrhage, started having bleeding. And, they had taken her back to the labor delivery room a couple times, made sure that the placenta was all out, that the uterus clamped down and so on. And each time they thought they had it under control, but she'd continued to bleed. And so, they had, in fact, by the time they decided to send her down to us at the university, she'd had 13 units of blood. So anyway, they sent her down. I remember it was a weekend. It was on a Saturday. The B.J. Brown, who published this study, one of the residents, and a faculty took her to the OR and found she had a belly full of blood, in addition to the bleeding, vaginal bleeding. They couldn't tell exactly where it was coming from. They ended up doing a hysterectomy, thought it was from down around the lower uterine segment or the vagina. They oversewed the vagina and so on. They thought they had everything controlled. They put her in the ICU, and I came on Sunday morning. And the first thing I heard was, that patient is still bleeding. She's in the ICU. Now she's had, 30 units of blood. I thought, we're going to take her back, and we're going to be in the same boat that they were. We're not going to be able to find this bleeder. Well, this is when embolization was first starting. And embolization was used for bleeding livers and GI bleeding and so on. So we called in our interventional radiologist, who was starting to do all this stuff. And I remember he said, yeah, I'll be in. We'll get it stopped. Like there's nothing to it. Well, next slide. He threaded a catheter up the femoral artery. He injected some contrast material. And on the left there with the arrow, you could just see the blood spurting. It was a retroperitoneal lacerated pudendal artery. We'd never found it. I know she'd have a big hematoma. We'd be digging around there. We'd never get it stopped. So anyway, what he did, he just put some saline in the syringe. He put some gel foam in. He injected it. And as you can see on the other one, she never bled again. It was a life-saving procedure, just a case report. And you know what's happened with embolization ever since then. Next slide. Now, there are other papers that have been very harmful. This is a famous one that you probably are familiar with. And this is the Lancet study that showed that there was some relationship between vaccinations and autism in children. Despite the fact that the study was declared fraudulent, that it was retracted in 2010, it's done tremendous harm over the years. And there are still many, many people that resist vaccination because of this paper. Richard Smith, who was the former editor of BMJ, said it's a paper that never should have been published. But I would argue that the same sort of pattern is still occurring today. These weak associations and picked up by the media and publicized and cause all sorts of worry for patients. Next slide. Here, for example, is a paper that was published a few years ago. How many of you remember this one, where autism was associated with induction or augmentation of labor or oxytocin? When I saw that, I thought, oh man, you know, all the OB patients in the country are going to be worried about this, about oxytocin, about induction. It turns out it was a totally inaccurate database. It was an association only. You can never show causation with these epidemiologic studies. When logistic regression modeling is part of the analysis, I always get a little bit suspicious. And it was barely statistically significant anyway. It almost crossed a 1.01. Anyway, it was widely publicized by the media and caused a lot of harm. But there were a lot of letters to the editor, including ACOG and so on, that criticized the methods and the findings, and I think it finally passed over. Next slide. These are the associations so far that are associated with autism, just a few of them. I mean, you know, there are all sorts of things that come up, and these are all epidemiologic studies. There are all kinds of things. Maybe some of them are, maybe some of them aren't, but not all of them can be. Next. So my point is that there are a lot of overstated conclusions that are very common with epidemiologic studies, a lot of misleading results. They're associations only, but they're implied as causation. And they'll often say there is a 3-fold increased risk of this. Well, you have to know the denominator. A 3-fold increased risk can be 1 out of 10 versus 3 out of 10, or it can be 1 out of a million versus 3 out of a million, which doesn't mean anything. And so anything, if you get a big enough group, you can absolutely find something statistically significant, because there are a lot of confounding variables in these studies. But they're really clinically irrelevant and shouldn't be used. Next slide. I once sent one of these papers to David Grimes, and I said, how are we going to stop all this, David? And his answer was this: all of these epidemiologic studies with small odds ratios should end with the statement, we found a weak association and we have no clue what it means. And I would like to see that in the end of all of these papers. Next slide. John Ioannidis, who I admire, is an interesting guy who has criticized the literature a lot in the past decade. He published this study, Why Most Published Research Findings Are False, and pointing out several of the things that I've already talked about. This was the most downloaded document of all time on PubMed, and he's continued to be critical of some of these studies in the literature. Next. Well, what I tried to point out and do with the Green Journal is this, that we wanted to publish clinically relevant papers only. You'll notice we didn't have any rat studies and things like that in the Green Journal. We wanted to make sure that the study design was valid, that there was a stringent review process, and that we publish results that physicians can trust. And I hope we still continue to do that. Next. Next slide. Because there's a new problem now. And the new problem are online journals, many of them predatory journals. I had 3 requests this morning to submit a paper to 2 of them, and the other one wanted me to be on their editorial board. How many of you get these emails? You get them all the time. And why is that? Well, because the original idea was good. You know, publishers make a lot of money, and they have firewalls so you can't get to the paper unless you buy a reprint or something at $35 or whatever it is, especially the third world. And so this was an attempt to have authors or grants or whatever pay for the publication, and then they would be open access to everybody. It was a good idea to start with. But what these journals found out very quickly is a money-making scheme. For example, this author here created multiple versions of a paper that obviously had fatal flaws. Any reviewer would have picked it up. This is wrong. He sent it out to over 300 journals, and it was accepted immediately by 157 of these, over 60%, with minimal or no peer review. So what we're getting is a whole contaminated medical literature now, because it is a money-making scheme. Next slide. Right now, go ahead with the rest of it. There are over 8,000 online journals now. Over 400 of them are published in publishers, with a third of them in India, but they usually have a United States address. They advertise for papers and to be on the editorial board and so on. And the reason is because the more papers they can publish, the more money they can make. So they're not particularly interested in peer review or anything like that. You can put up the rest of it. They usually, there's one more line. They usually charge the authors about $900 to $3,000 to publish their paper. Now, you know, around the world, there are authors who are very desperate to publish a paper, to get promoted or for various reasons and so on. So they're still publishing, and they are pretty naive sometimes and don't realize that these are just predatory journals. So this is a big problem in the literature and kind of contaminating the literature these days. Next slide. So for authors and readers, you have to be cautioned, sort of like this sign. It says, this sign has sharp edges. Do not touch the edges of this sign. And then down below it says, also, the bridge is out ahead. So anyway, with the medical literature, you have to be a little cautious these days. Next. Well, what is the bottom line? You know, it's really easy to be too critical of studies. Anybody who's done research, you know it's hard. It's really hard to do a good study and to set up the study design and do it right. There's no such thing as a perfect study. And still, a little healthy skepticism never hurt anybody, particularly with the first study that's reported. Meta-analyses, randomized trials, practice guidelines, they can be just as flawed as any other study. Next. So my advice is don't waste your time. Stick with reliable and useful sources. So, you know, I'm talking about the Gray Journal, the Green Journal, New England Journal, JAMA. The Cochrane Library is a good source if you have access to it. I think the ACOG practice bulletins do a good job. They do it in an objective way. They try to do it in an evidence-based way. They don't have conflicts of interest, and so I think those are the things that we should depend on. UpToDate is a good source. I'm sure some of you use those. I use it myself. I also put in the medical letter because a lot of people aren't familiar with that. How many of you know about the medical letter? Some of you, but I've used it ever since I was in general practice many years ago. It's a very objective and very useful way to look at drugs, new drugs particularly. They will have tables that compare the cost, the efficacy, the side effects and everything of all the drugs in that category. And so if you ever want to look to see what's reliable with a particular medication, it's a very good source. Next slide. Well, I've talked a little bit about skepticism, and I admit that I'm a skeptic sometimes, but you have to be skepticism about these things. First of all, guest speakers. That's me. You know, you can take what I say in a grain of salt. But if you think about it, a guest speaker can get up and say about anything they want to. It's not necessarily peer-reviewed, and most speakers want to come up with something spectacular, something new and spectacular. It may or may not turn out to be true in the long run. Database studies. These are very popular now, and a lot of them are administrative databases that were never meant to do research from, or they're birth control data, or birth certificate data, or death certificate data. You know, and those have been proven to be inaccurate. In other words, the guy dies of a heart attack and the doc writes on the death certificate, heart attack. Well, you know, it may or may not have been. And so those are unreliable database. I've already talked about epidemiologic studies. Decision analyses, this is a variation of meta-analyses, but even softer data and more assumptions. Before and after studies maybe are worth a comment because they're common these days. In other words, with safety and with new protocols and so on, it's common to compare what happened before you started the protocol or the new regimen with what's happened after you started. And what often isn't taken into consideration is there are a lot of other things that changed besides just the protocol. Maybe the newborn ICU changed the way they are treating patient babies and so on. So you have to be a little careful about those. There are a lot of confounding variables sometimes that aren't accounted for. Drug company-sponsored studies, I think you have to be cautious about them. If you look at the New England Journal, just look at it the past year, about 50% of all the papers in New England Journal are on new, very expensive drugs. And almost all of them are sponsored by the company. Almost all of them are written by authors that either work for the company or associated with companies or consult with them. So you have to be a little careful about them. Sometimes they overstate the conclusions. And then the advertisements on TV every night are just totally embarrassing. They're just totally wrong. It's like P.T. Barnum, you know. Anyway, I won't say much about them. Next slide. So what needs to happen? Well, first of all, I think that all studies need to be simplified and clarified. The statistical methods that are being used now more and more complex. And the more complex they are, the more suspicious you get of them. I think we need to have studies that are simplified and clarified for all of us to read. I think all new drugs and all treatments should be compared to the present drug or treatment, not just to a placebo. I would like to see cost comparisons required for all these studies. In other words, they're almost never included in the paper. Reject epidemiology studies with odds ratios less than 3 to 4, and that's most of them, and require absolute values and number needed to treat. Disclose all conflicts of interest, regulate predatory online journals. The problem is nobody seems to have an authority to do that right now, but it really needs to be done. And then publicize, prevent, and severely punish fraud. Next slide. So evidence-based medicine, I'll say, is important. I don't mean to minimize that. But you know, from a patient standpoint, they expect a lot more than that for good medical care. And it's important, I think. Compassion, empathy, communication, clinical judgment, common sense, and honesty. And sometimes we don't emphasize those things enough. Next slide. Oh, I was just going to throw in one unrelated slide here. This, you see this guy on the left here? This is a homeless guy, and Dr. Adair saw him downtown walking along, and he went up to him and he said, you know, if I give you this $10, will you buy beer with it instead of dinner? And the guy said, no, I stopped drinking years ago. And he said, well, if I give this $10 to you, will you use it for green fees at a golf course instead of food? The guy said, are you crazy? I haven't played golf for 20 years. He said, he said, well, instead of giving you the $20 then, I'm going to take you home for a terrific dinner, a shower, a dinner cooked by my wife. The guy was astounded. He said, won't your wife be furious for doing that? And he said, well, that's okay. It's important for her to see what a man looks like after he's given up drinking and golf. And I'll just stop with that and answer any questions here. We're going to play golf tomorrow, by the way. Early. I hope we don't get routed.
Was there a question back there? No? Okay. So the predatory journals, one of the thoughts that I have is that in terms of faculty evaluation and CVs, et cetera, they should not be counted. That's just one way of quickly getting to the heart of the problem. But that's one of the things that, for particularly residents, younger faculty, that's not even worth wiping your rear on. Okay, so that's my opinion. But anyway, any other questions?
Yeah, I will say it's important for promotion committees to understand this. You know, usually they will just take a long CV of a faculty member to be promoted and so on. They'll look at the number of publications rather than the quality and so on. And so sometimes they miss that. But I think they're getting more and more attuned to this now.